Good evening, friends. I will be talking about femur head fractures. We also call them Pipkin fractures. And when we look at the injuries, we understand that there has been case reports about these injuries about 20 years back. And then we started having the series of these cases. When we see all these series, till 2011, we had 365 Pipkin fractures of all reported in the literature, mostly Pipkin 1 and 2 type of injuries. Then we looked for the big series. We had a series published in 2010 of 110 cases. But again, it was a collaborative data of many centers, and this was a study of 16 years, a long span of time. We at our place, working in an institution which is a kind of a center, we had 150 cases which we managed in a span of 20 years. And what I'm presenting is the experience of these cases which we had in this time. When we look at the classification system of these injuries, we have Chiron classification, we had AO classification, which has recently been instituted into this area. In that scenario, we usually have not started using this classification, but as compared to this, when we look at Pipkin classification, with which the surname of Pipkin has gone in, or the another classification, that is the Brumback classification, which is much more elaborative, and that is what I'm using right now. What we say as Pipkin 1 or what we say as Brumback 1A means a fracture which involves the lower part of the femur head, and this is a small fragment. In this kind of a situation, it is primarily a dislocation hip which you reduce. The fragment tends to settle down at its anatomical point, and then it becomes practically a hip reduction, a dislocation which has been reduced. And when you subsequently follow these cases also, the fragment settles back at its own position and eventually unites. On MRI, maybe this was taken after about a year of fracture, it still shows a kind of a separation, but radiologically, this looks united. Another case with the same kind of an injury at a follow-up of 6 years, doing well. There can be a problem of a degeneration because eventually it was a dislocation. So this is a 10-year follow-up of a patient of the same injury where the fragments settle down, and whatever the changes are, they are the result of the dislocation hip rather than the fragment. Now, in this situation, when we look, we have these many cases. The primary management, which is supposed to be, is the non-surgical management. Many of these cases are not operated upon in this kind of situation. But if the fragment is relatively large, now here we have a 22 years male with both side dislocation and both side femur head fracture, where on one side the fragment is bigger and we fix that fragment. On the other side, we did not open, made it a conservative treatment. He also had another injury at the knee joint. As we know, these are mostly dashboard injuries, and there we had this kind of a fracture. Such a fracture can have a combination also, like here we have a trochanteric fracture, hip dislocation, and this kind of fracture which needed the reduction and fixation of the femur head fragment also, as well as the trochanteric fixation, and this is the follow-up of subsequently for 2 years, showing the head being well subsequently also. Now, it is well accepted in one of the literature is that non-surgical treatment is acceptable when anatomical reduction is achieved, if joint is stable and fracture is inferior to fovea and is not likely to be probability. But the care which is to be taken after this reduction is we must have serial radiograph so that we can see whether the reduction is subsequently maintained or not. If there is a malunion, is it a problem? That becomes a question. Here is a patient who had a malunion of that fragment, but is able to sit and squat comfortably. So this is a follow-up of 4 years. There could be a malunion which gives impingement, the anterior impingement, and here is a scenario where this patient had difficulty in sitting, restricted rotation, and he was not comfortable, so he demanded a kind of a surgery. We took out, excised out that fragment from that place, and he was comfortable subsequently. So a fragment, if causes impingement, can be taken out because this fragment is anteriorly, so we usually use a Smith-Peterson approach. Another situation is that this fragment does not unite. Even if it does not unite, the location of this fragment is such that it stays down there anteriorly. So it's not an issue. This is a 5-year follow-up of such a case with the non-union with no problem to the patient. In the literature, one thing is very clearly being established in the recent literature, that if these fragments cause incongruency, if you look at the CT scan picture of this hip joint, you see the posterior joint space is less as well as compared to the anterior joint space, meaning by the fragment inside is causing the incongruency, and they could take it out arthroscopically. Now that is one way. And it's not only the excision, people have tried fixation of the fragment arthroscopically also in this kind of a fragment. So that is one of the ways it can be handled. There was a paper from an Indian International Orthopaedic which said that it is not the reduction alone, and all these cases must have a resection of this fragment, otherwise AVN will come. We feel that this was not a right approach, so we wrote 2 replies to this very paper that this is not the right statement. Conservative management does have equally good result as compared to excision treatment, so we should not really be looking for surgery in most of these cases. Now we look for Brumback 1B, which in Pipkin has been classified as Pipkin 4, meaning by associated acetabulum fracture along with the femur head fracture, which is small fragment. And when this is the scenario, what happens most of the time, it could be the same kind of a dislocation. You reduce the dislocation, you check for the stability of the hip joint stable, and this is the 4 years follow-up. You don't have to do anything at this situation also. Another case where there was a fragment which was not allowing the reduction along with an acetabulum fracture, we had to do the open reduction of that fragment. It was about 15 years back. As we reduced the hip joint, the acetabulum fragment also settled back. We did not operate, and this is the 5 years follow-up and doing a good outcome at that stage. But whenever there is a incongruency after the reduction, the fragment needs to be reduced well, fixed well, and along with the acetabulum fixation, the femur head fracture has been fixed, and this is 7 years follow-up with a good outcome at that point of time. If these injuries, as I said earlier, are part of a dashboard injuries, the knee joint is frequently involved, like in this case, where along the femur head fracture, along with the acetabulum fracture, the knee was also subluxated to a big extent, and we had to operate all of them to stabilize the acetabulum, to stabilize the femur head, as well as to stabilize the tibial, proximal tibia also, which we could publish subsequently as an innovative case in that scenario. Many times what might happen that when there is a femur head fracture, there is associated posterior wall acetabulum also fractured, and in this scenario, the instability of the hip is very high. What we have done is that it was difficult to reconstruct these small posterior wall fragments. We took a iliac crest graft, stabilized as a posterior wall, and this is the outcome which subsequently got a good outcome. So we published it after 4 years of follow-up, where we found that the hip is doing good. This is subsequently 6th year follow-up, and now this is his 8th year follow-up. Is still doing fine in this kind of a situation. Now, our problem in our country is the injuries which are reasonably late also. Now, this is a 4-month-old injury, the 22 years young man. The question was, should we reduce it or should we go for a hip replacement kind of a thing? But what is important here is this is Brumback 1. Meaning by the fragment is likely to be small, so we take it as a neglected dislocation. And in this kind of a scenario, in a young man, we thought of doing an open reduction, and this is what we did. We did open reduction of the hip joint. Anticipating avascularity, we made multiple drill holes across the neck to the head to make the viability. And this is his, you can see the follow-up at 2nd year, 4th year, 5th year. And then you see in the 6th years, 8 years, he is maintaining all his activities of sitting on the ground, squatting, and this is followed up at 12 years, he's still able to maintain his work very well. He's asymptomatic till date. Whatever the x-rays show, he doesn't have symptomatology to demand any more intervention. The similar situation happening in an elderly individual demands something different. Now, this was the scenario where there was a sternum fracture, femur head fracture, but at 62 years, we did not want to reconstruct it. We suggested a replacement, which this patient initially refused. But after further 2 months, he had a difficulty, so he accepted that option, and we reconstructed the sternum, we reconstructed the hip, and that way this is 3 years follow-up subsequently. Now we talk about kin 2, or we also say that Brumback 2 A type, meaning by no sternum fracture. Only the fragment which is there is a bigger fragment. It is suprafoveal, involving a bigger part of the femur head. And if you see this X-rays and then come down to a CT scan, same kind of a big fragment, but after reduction, it settled well. We monitored post-operatively. It did not display subsequently, and this is 2 years follow-up, maintaining a good outcome, good reduction. That's very well accepted at that segment. Many of the time, this small fragment might have lost viability and can go into avascularity, subsequently leading for a degeneration in this kind of hip, which can primarily be a result of a dislocation or could be to that very fragment, and may not be the result of a fragment fracture as such. But whenever there is a fracture, it is essential to get that fragment back to its position. And initially, we were doing most of these cases from the posterior because of the dislocation posterior. This was one of those early cases. We did it in 1995 when we reduced from the posterior approach. You see there is a heterotopic ossification after the 5 years of follow-up B2C, but it was not of that grade of brokers which required any intervention. But that was what we used to do at that stage. With the time, we started learning that once we have been able to reduce the hip joint, we don't have to go posteriorly, we just have to go anteriorly, reduce this fragment through a Smith-Peterson approach, giving it a kind of a tin-shaped incision, manipulating those small fragments with the Kirschner's wire, getting them reduced and then fixing them. And this kind of a intervention is, in this scenario, you see attempted close reduction, but the fracture fragment of the femur head actually rotated 180 degrees. And so we have to derotate it after the capsulotomy, derotated it, fixed back, and this is, you can see, 2nd year follow-up, 4th year follow-up, 6 years follow-up, and you see 7th year follow-up, 10th year, 12th years follow-up. Another case, same kind of a situation, attempted reduction, fragment swinging back 180 degree, you see a 6 years follow-up, and now this is 17 years follow-up. Again, hip shows these negative changes at 11 years, patient is asymptomatic. So radiologically, one may feel the degeneration is coming by 17th year, but patient doesn't have any symptoms. Another situation, same kind of a situation, we do a open reduction, fix this from the Smith-Peterson approach only, and this is his 14 years follow-up, and on X-rays does show a kind of a radiological damage, but clinically he is able to manage all his activities. What has been accepted in the literature is that modified anterior, also for Smith-Peterson approach, gives 80% good and excellent long-term outcome in all these cases where hip is reduced because the fragment is primarily anterior-inferior. It has also been accepted in the literature that when hip is still dislocated and you want to do the reduction, then trochanteric flip osteotomy, also called the Gaines approach, is the way to go for. And that is what a decision has to be made. When the hip is dislocated, not reduced, or difficult to reduce, go with the Gaines kinds of osteotomy, where the posterior approach, you do a osteotomy of the graded trochanter, flip this graded trochanter anteriorly, dislocate the hip joint, get that fragment back to that position, and then fix that fragment onto its anatomical position after getting a compression across, and then the re-reduction of that hip back to its position. So it is also called so-called a safe surgical dislocation, and that is what has been now recommended in all those cases where it has not been reduced. Yeah. And This has been established in the literature to be a reliable approach in managing these injuries. Now, if we do not have an acetabular fracture, we can actually go with the Gibson incision also, where we do not go anything below the piriformis and we go between the gluteus maximus and medius without going in between the maximus also, and we can avoid and go that interval and stay above the piriformis, do the philiposteotomy, go anteriorly. So in case where we do not have to do any posterior fixation, we can stay with the Gibson, and then subsequently the philiposteotomy can be done in this kind of a situation. Another situation is what is to be used for fixation. We have used simple screws, we have used Herbert screws, and lately we have used this biodegradable screws also, which on radiology gives very good picture, as you can see in the X-rays, as compared to the Herbert screws. The other screws, these screws cannot be visualized on the X-rays, and they have to be quite fine. The problem which we had with these biodegradable screws was that many of these screws gave a lot of discharge, which was aseptic, but it did maintain itself, and we found it out that whenever these screws are exposed to a joint fluid, there is some kind of discharge, and subsequently we stopped using these screws. But there is a literature just published in 2018 where it has been accepted that these screws were good, or they were acceptable in the quality of life of the patient. Now, when we look at the complication of these from back 2 injuries, or so-called Division 2 injuries, avascularity of the femur head is obviously a possibility due to the dislocation itself. Now, in this case, we were not proactive to search for it. This patient manifested clinically after 3rd year. We went for a curettage, we grafted, and this is subsequent follow-up at 9 years. He still maintained the same pattern. Now, considering that GANS approach is an accepted approach, in these cases where we did not have a reduction done, we went with the GANS approach, and then we had a good outcome. This is a 7-year follow-up of that GANS approach patient. Another situation, GANS approach in late cases does not make us immune of avian. This patient, when it was dislocated, when we just tried to aspirate the femur head to look for the avascularity, we found this was not giving us that much of a blood aspirate, which even published a technique also, that there was a relative avascularity. The MRI showed that avascularity at 3rd month, and subsequently we did a kind of a grafting after gold decompression. This patient healed. This is a 4 years follow-up. Another patient with the same kind of a GANS approach after the philiposteotomy, we did a fixation, and this is a 2 years follow-up after gold decompression stem cell, because she also developed a kind of a avascularity, and this is subsequently her 7 years follow-up, maintaining well up to that avascularity which was seen on the MRI. Another situation which can come back is osteoarthrosis. This is a patient who had the same kind of injury. We fixed it up, but by 6th year, radiological signs appeared. You see his ability to sit was quite good. It was 9th year when he was symptomatic enough and able to sit on the ground. He also showed to be bad, and it was 10th year when he accepted replacement as an option, and in this year then we replaced his head. And now you see his ability to sit was quite good. It was 9th year when he was symptomatic enough and able to sit on the ground. He also showed to be bad, and it was 10th year when he accepted replacement as an option, and in this year then we replaced his head. And now you look at the head which we had cut it out. There was an avascularity of the inferior fragment and a vascular superior fragment. So it can be noted that these fragments, when in reduced back, fixed back, may not regain hold of the vascularity, and there does remain a kind of a difference. If there is a avascularity, it may be significant, but many times it may be not very significant enough. And this kind of a situation, this patient started having avascularity, then this was 2 years follow-up, and then we look at it 7 years follow-up. The hip is still working, but we do see a lot of avascularity and a lot of degeneration developing in the hip joint. But we have to be very careful whenever we do a GANS osteotomy or GANS approach. We have to be careful, otherwise this is one of the complications which was reported in one of the WhatsApp group. You can see it out how a bad GANS approach has been done rather than getting the hip. Now we have got this totally dislocated hip in that scenario. Our same problem of neglect still comes into our thing. In the back 2 injuries also, you see the femur head is reduced more than a half. So it is 1/3 of the femur head left, and incidentally, there is no other fragment. This has been resolved, and it's already a 4-month-old injury. Now, at this situation, we had nothing to reconstruct. So what we did was we use a allograft head of the same size, cut to the same level, fixed accordingly, and in this situation, we got a reconstruction of that femur head with the allograft head. We were doubtful about the vascularity. We did an MRI. MRI showed a kind of a vascular pattern, and then this is a 2 years follow-up, and this is a 4 years follow-up, and then you can see the video. Sorry, you can see the video of the movement in this kind of a situation. Sorry, so the video is not working, but she has been able to walk around. Now, Brumback 2B, meaning by the big fragment, but acetabulum is also fractured. Now, in this situation, acetabulum fracture, in this case, again operated way back in 1996 or 7, we reduced the hip joint, fixed the hip joint. At that stage, we were not doing the acetabulum, but acetabulum fell back to its place. But you see the degenerative things appeared in the second year. Radiologically, patient did not have a problem. So we went for 3rd year. This is his 6th year. You can see his 12th year and now the 18th year. Same hip is working well till 18 years. So we see the signs of radiological way, but clinically you can see his abilities to sit, squat, stand, all functions are quite good, even that follow. The problem in India is another neglected thing. Now this was a 3-month-old injury. Patient came 3 months late, and when we counseled him that at this age he cannot do much in this scenario, he did not want to have a replacement done, but he accepted that he will keep on coming. He came after 4 years with the kind of a hip which was stable enough to make him standing, and this is 6th year he again came, and we see a beautiful acetabulum or pseudoacetabulum form in which he was able to stand on either side well, he could split. So this is one of the ways our patients had well. Now there has been more this thing that in all these cases we can change up approach. If you look at the relatively a busy slide, you can see very many approaches has actually been used for these cases, but Gaze approach has still remained the standard. Now question comes whether anterior approach is always good or posterior approach is bad. This analysis did in 2016 says there is no difference in complications, osteonecrosis or arthritis, whether you use an anterior approach or a posterior approch for Pipkin 1 and 2 fractures. So we go with one of our chapters. We have made a algorithm that in Brumback 1 and 2A cases, we try gentle close reduction. If it is reduced, it's reduced anatomically. We just watch and monitor. If it is not, we stabilize, and usually we use a Smith-Peterson approach. But if we feel we have not been able to reduce gentle close reduction, we do not force it. Then we go for a Gaze approach, and if it's a small fragment, we may excise it out. Big fragment, we always fix it back, and this Philip osteotomy and Gaze approach remains a standard approach for that kind of a thing. Whenever acetabulum fracture is associated, making it 1B or 2B, in that scenario, we again always almost go with the Gaze. We always stabilize the acetabulum fracture when needed, and likewise with the same approach, we stabilize the femur head also. Now we look for Brumback 3 or a Pipkin 3, but Pipkin 3 did not describe something Brumback 3A, which just means fracture neck femur with a dislocated hip. Now in this kind of a situation, this is the case. He was a 60 years male. We did not try anything else. We went for a hemiarthroplasty, and this is the hemiarthroplasty done. Another case of a similar type in which only femur head and neck was broken, hip was dislocated. We stabilized the acetabulum because acetabulum was broken and did a replacement in this case group. The problem was in a young patient. He is a 20 years young boy, had a fractured femur neck, had a dislocated hip, had a fractured femur head. Now in this situation, when we opened up, we had all the femur head in our hand. We reconstructed the head back, put back into the neck, stabilized the neck, and if you see down there 6 months later, the head showed a viability. And 6 years later, this patient had gone out of country. He came back after 6 years, and you can see his hip was functioning, but he had a kind of a avascularity developed, but he was able to sit. No, he was not able to squat very properly, but his otherwise walking function, everything was okay. So reconstruction did help in a younger age, even in Brumback 3. But this another patient, another boy of 18 years, had the same kind of injury, who did the same kind of a reconstruction, put it back in the same way, but his head started collapsing in his third year, and eventually total collapse. We had to replace this femur head in 2011 and do the THR. Another patient with the same kind of a lesion with a psoriatic arthritis, after the reconstruction, developed a significant flare-up of the psoriasis, developed an infection, and we eventually had to do a girdle stone after taking the disease head out, and he was 7 years follow-up. Another case with the same kind of a situation where we had fixed the femur head with the biodegradable screws, fixed through the GANS approach also, at the same kind of a situation. He also got infection from, basically could be the discharge which persisted, and eventually we had to take the femur head out, and he had a post-septic arthritis hip, and this he was still disabled, and we do not want any more surgery at that point of time. What literature says in these kind of a comminuted fractures, they say you should still try to reconstruct in a younger patients, but you may have to do a replacement in elderly patient. That is all the literature which has agreed that in younger patient you can try osteosynthesis. So in Brumback 3, we do perceive the chances of success are not very high, but in younger patients still we should try. Now we come to Brumback 4A, a kind of a indentation fracture which Pipkin did not describe. It's a Brumback definitions of which we tend to see in obturated dislocations very often. You see here also a classical, and then you see on the first X-rays over there an indentation, and subsequently see after 2.5 years we don't have any effect on the joint of this indentation. Another situation, another case where one side had a fracture neck femur which was fixed, the right side had an indentation which you see in the magnified X-rays also. Now we were not operating upon, but we tend to see what happened to this case. 6 years later, other hip was done well. This hip did not show much of the changes, though we see the changes, the indentation still in the head, and it's 8 years follow-up, it is still okay, but the other side we have already removed the screws also. So this is the kind of the outcome. So indentation has actually made up the difference. Still 8 years, it might make it later on, cannot be said. In literature, we do see that people have now started doing this chondral graft into this area, taken from somewhere else so that they can build up the bone and the cartilage in that area. Another fracture which has been described is Brumback 4B. There is a shear fracture. It's not an indentation. It is, we also call it sleeve fracture. Again, Pipkin did not describe it. In this fracture, what happened? With the same kind of a mechanism, a part of bone is sheared away. Now, incidentally, we have got an X-ray taken 7 years after the injury. You see the same fragment, shearing fragment, and it's at its own side. Patient doesn't have a problem. The fragment has not moved in this 7 years, and it's still at its position, and patient is still a happy patient. But if that fragment is big, you can see down there in the X-rays and the CT scan, this shearing, we had to fix it back, we fixed it back, and it is 4 years follow-up of that very case. Again, another thing which Brumback did not describe, the Pipkin did not describe is Brumback 5. There is a central dislocation. Till now, they were all posterior dislocation. Now it is a central dislocation. This is one of the cases where there was a transverse fracture along with the Pipkin fracture over here. In this approach, we went anteriorly, started with the iliofemoral approach where we could access the femur head also, and we could stabilize the acetabulum also. This is her X-ray. At 10 years, she started becoming symptomatic. At 12th year, she was symptomatic enough to require a THR, and this is 19 years later. In last year when she came, she had a THR follow-up, and the total follow-up from the injury of 19 years. Now, there could be some more unusual things. This is a case where there is bilateral elan dislocation with the femur head fragment on one of the side. At the time of injury, we stabilized this patient. At 3 years later, she has a reasonable outcome which we could publish also. Another situation, again Brumback did not describe, was much more combination, but the lower part of the femur head was intact. upper part was comminuted, so we went for reconstruction. But you see, the upper fragment did not have a vascularity. We washed for it, removed one of the screw after dislocating it also, but still it went into degeneration. And by fourth year, we did replace this head. In sixth year follow-up in 2011, the femur head is okay. Same situation happening in another patient who was just 22 years old. We reconstructed those fragments. But at that stage, it looked to us this fragment is likely to go in the same bad way, but she was not having any symptom. And once she was not having, we still hold on, and at 12 weeks, things looked still bad. And at 1 year, we had advised her non-weight bearing or minimally ground touching weight bearing. Things were bad, and at that stage, we thought we had lost the joint. But again, she did not have much of the symptomatology. And then, 3 years later, when she came, her head has reformed. The reconstruction of the femur head, and then look at the ability for her sitting and squatting. And again, we contacted this patient after 7 years, and you can look at the load out. From the 3rd year follow-up till 7th year follow-up, her all abilities had improved. The head is reformed in all that scenario, giving us a hope that if the patient is not having any significant symptom, we cannot rely on X-rays alone to make a decision. We must try to conserve the head as much as possible. And this has always been an option. And in one of the case reports in the literature also, they have tried reconstruction, but they have noticed the degeneration coming very early. So when we look at the kind of a series, again, one of the papers, they said they could get 50% of the good result, and they had a reasonable number of cases which were operated upon, and about 12% cases were non-operated, all of them. In our series, a part of it which had published way back in 2009 in Journal of Bone and Joint Surgery, now from that onwards we have got a reasonable follow-up. And in 30 patients we had a follow-up of more than 5 years, and we had a follow-up of more than 11 years in 8 cases, 8 to 10 years in 6 cases. What do we see? The outcome that overall, when we looked at the results of those 100 cases, 50% were normal radiologically and clinically. There were 10% who were radiologically had a significant problem, clinically no problem. 20 more percent had radiologically a vascularity, clinically no situation. So 20, 10 and 50, 80% of the patients might have some radiological issue but no clinical issue. 7% were compromised. They did not want a THR. While early THR was done in 6%, late THR was done in 7% of the cases after 5 years. So this is the kind of the outcome we could get in all these other cases. And again, a literature which was just published in 19, that despite the optimal management, the rate of complication after femur head fracture may reach as high as 50%. But we feel that we have been that way comfortable as far as the clinical outcome is concerned. Now, a question about whether this GANS approach does increase the vascularity, at least in our series. The cases which we did with GANS, the cases which we had done with the posterior or with the Smith-Peterson, or those cases where we had done a close reduction, we did not have any difference in the outcome. Maybe that we are getting our cases relatively late when the dislocation effect on the ABN has already been there and GANS has not been able to reduce that incidence. So we still feel that another algorithm which has been given, which is different for a younger patient and relatively different for elderly, because in elderly, all Pipkin fractures, second and third, and Pipkin 4, they feel primary replacement can be done. But younger patients, we go with all the methodology to get this femur head back. We feel that we may not have to be that aggressive. We still will like to save all Brumback 1A fractures primarily by close reduction. Wherever the fragment is big enough, we may excise it out or fix it back. In Brumback 2 fractures, also called Pipkin 2 fractures, also invariably they will need a fracture fixation. We can use it with the Smith-Peterson if the hip dislocation is reduced, or we go with the flip and GANS if it is still reduced. Brumback 3 cases, in young patients can try reduction, in elderly hip replacement standard. Brumback 4, that is indentation. Right now, there is not much to talk about. Maybe in the literature we might have chondroplasty and all those things. Right now, we have not found any significant difference, even with the conservative management. From back 5, meaning by a lot of injuries and medial dislocations, we might require reduction fixation, and then there will be many atypical fracture patterns also, which need individualized care in all those cases. So this is what I feel our protocol in the day of today, and I'm thankful to all these my patients who have been coming to me for such a long period of time for their follow-ups. Thank you, listeners. Now open for questions. So the question is, what is our approach for open reduction of posteriorly dislocated femur head? So as I have said it out, that in open reduction, if the femur head is still dislocated, Gann's approach remains the primary management. If hip is reduced, then Smith-Peterson is the approach, because this fragment invariably is antero-inferior. Another question is, dislocation of ball and joint, whether resemble with indentation fracture or not. Dislocation per se may not lead to indentation, but obturator dislocation invariably may cause indentation, and that is on the anterolateral part, which may be weight bearing, which may not be. If it's weight bearing, it might have an issue with that, and we need to observe. Now, the today's technology, we can transplant a part of inferior. In some of the cases when we were operating bone, we did shift a osteochondral fragment from lower part to upper part. We need to see the results, only then we may be comfortable saying that. So what is the post-operative protocol? The protocol in the post-operative period, because this is a kind of a hip dislocation, which we might vary with a little of the approach. What is more important in this any surgical stabilization of the hip joint is to get a range of movement. And what is important here is that this range of movement must be achieved as early as possible. So we start range of movement but no weight bearing till a period of about 6 weeks, when we ask all our patients to be sitting cross-legged. Once they're able to sit cross-legged, subsequently weight bearing is also started, and by depending upon whether we have associated fracture, so depending upon that, otherwise, as the weight bearing area is not fractured in most of the Pipkin 1 and Pipkin 2 cases, we do allow them partial weight bearing at 6 weeks and technically going for full weight bearing by 9th or 10th week. In Pipkin 1 fracture, we may be little earlier also, because major weight bearing area is not affected in that situation. Another question is that a lot of cases having AVN afterwards, and we need to go for core decompression. And whether we can do a core decompression at the time of primary surgery? Yes. In those cases where we have a delayed reduction, if we already have got a delay in reduction more than 6 hours, more than 12 hours, definitely we have done it also. We did it in 2 months old, 3 months old also, but there is definitely, we can try. So when we look at the literature regarding the outcome of a core decompression in a post-traumatic AVN, things are a little different. This does not, we have published that paper also, and incidentally that's the only publication regarding the outcome of a core decompression in the world literature in post-traumatic AVN, published in the journal Hip Injury. And there we have found it out, the outcome which can be expected in the early stages of a non-traumatic AVN to be 70 to 80%. In post-traumatic AVN, it is not more than 50%. So a lot depends on the amount of avascularity of the femur head. If the avascularity is less, maybe the core decompression may also be effective. If avascularity is more, it may not be effective, because core decompression primarily we do in non-traumatic AVN is for decreasing the edema. Here there is directly an ischemia, so it may be or it may not be that effective. Another question is again the same post-operative protocol which I have already talked about, and now is the question is, do we have experience with cartilage implants? We have started using the cartilage in the weight bearing area whenever it is crushed, but we do not have a long follow-up to say something. Right now with the MRI picture, it shows that it is being taken well, but we definitely need a lot of time to see eventually what will happen in that area. Literature, there are reports, there is coming up more and more literature about it, but we need to seek out. Another is, can you elaborate the SP approach video for reduction of the fragment? The Smith-Peterson approach is a very standard kind of a approach in which we go anteriorly and we go taking the vessels, taking the muscles in between the sartorius and the TFL. It is the internervous plane, and we try to reach, and we might have to reflect the rectus attachment from the anterior spine. We get over to the hip joint. Here at this place, we do a capsulotomy, little away from the labrum, and a kind of a T kind of incision in which a vertical line and the two flaps taken apart. And incidentally, for all Pipkin 1 and 2 fracture, we are directly over to the inferior part of the femur head, and that I have shown that they can be manipulated, they can be brought back, even 180 degree of the change can be brought back to that very position. The next is about follow-up cases did show changes in femur head, how the patient did well. Yes, that is very important. That's what I was saying about it, that the radiological changes are there. And these, because the follow-up is relatively longer, 7 years, 10 years, 12 years, 14 years, these changes are a part of a subsequent outcome of a dislocation hip. Many of these cases may not have changes, many of these cases will have changes, but whether they manifest clinically or not is important, and our perception is still that they are clinically acceptable by the patients. We do not try to take care of the radiological abnormality. As long as we can prevent the femur head from going for replacement, we must, till the patient is disabled enough to demand for surgery. That is what we do. Another question is, while using Gann's approach, do we visualize the retinacular vessels and also verify the vascularity of the head? A very interesting thing. Not only the Gann's approach, it's very interesting with the Smith-Peterson approach. When you hold this fragment and pull it up, there is always a retinacular vessels on the anterior inferior side, which not only help in the vascularity, but at the time of reduction help us to realign the fragment also. So because that is coming from inferior side, so it tells about what is inferior side, what is superior side, and we can definitely anatomically put it back. When we go for a Gann's approach also, we have to be very careful during the dislocation. We should not be really jetting it out. We have to take care of that fragment also. And if we are careful about getting that fragment back to its own position, we do see it and we do verify and say it helps in realignment of the fragment also. Another question is, what is our experience regarding core decompression grafting, light bulb or trapdoor method after surgical dislocation in Pickett stage 2 osteonecrosis? Now, my question here, the question remains, are we talking about post-traumatic? As I have said it out, all these measures are reasonably well, literature has got good examples of using light bulb or trapdoor method or core decompression. But in a traumatic kind of a situation, we don't have literature. There is no cumulative series. And when I tried to look for literature, we could find that our series was the only one available in the literature, where we found, by looking at the outcomes of these cases where we did core decompression only, we did not go for light bulb or trapdoor method, our perception is that all these things are little morbid for the hip joint. And when we know in a post-traumatic kind of a situation, these hips are most likely to go for a replacement at some stage of point. We do not want to make a big difference in the local anatomical structure so that their eventual DHR is not affected much. So we have not done trapdoor and light bulb in traumatic AVN. We have done a lot of them in a non-traumatic AVN at these stages, and we have been able to get good, and the literature also supports them. But as far as traumatic AVN is concerned, we are still conservative about these things, that we do give core decompression because it does not alter much of the morbidity, and still we can get 50% of the cases treated. Next question is, have we tried stem cell? Yes, I have shown 3 cases also, and we have been using so-called stem cell right from 2003 and 4 onwards, and now we have got a 10 years follow-up of most of our cases where they have done well. But Again saying the same thing, that the overall outcome of a traumatic core decompression even with the stem cell is not as good as is with the non-traumatic AVN. So the best effort we have done is the traumatic also with the stem cell is also, but it cannot be as good as in a non-traumatic situation because it is not the stem cell primarily, it is the core decompression which is the primary things. And whenever we add stem cells, we add into the area of necrosis. If our decompression does not help, we may not be able to have the cells also very effective. So it's the access to that area, curettage of that area which is done by the core decompression. There, if it is adequate, our stem cells are likely to work in that situation. Another question is, in case of a femur head fracture with ipsilateral subtrochanteric fracture, which one you feel takes first? Femur head fracture will definitely need fixation, but if the subtrochanteric fracture is the situation and femur head hip has already been reduced, we will go for a subtrochanteric fracture fixation. But most of the time, we look at the kind of a displacement. Many of the time, we may have a same kind of a fracture in which the approach could be same and we can fix both at the same time, as I showed one of the cases where we did the same, rather two cases where we did both the things in the one go. But if the hip is not reduced, in that case, we will do the reduction first, and once we are doing the open reduction for it, we might fix the femur head fracture also, and then we will fix the subtrochanteric fracture. Next question is there positioning for immobilization? No, we allow the patient to be ambulatory after third post-op day. We advise keenly that they must do the hip movements because we have entered the capsule. And the problem with the capsule is if we do not stretch it to an extent, they become relatively stiff. They make the joint stiff. So we mobilize the joints very early, but it is non-weight bearing, and depending on whether we are dealing with Pipkin 1 or Pipkin 2, we will have that kind of a post-operative weight bearing protocol. Another question is the size of side which helps to make a call before excision exercise how big? Yes, very important. The site invariably in all these cases in Pipkin 1 and 2 has been the anterior-inferior infrafoveal. And if it is infrafoveal and the fragment is not likely to make any difference there are two questions. If it is suprafoveal, it may affect weight-bearing area. If it is infrafoveal but big enough to cause so-called shim effect, meaning by femur head can wobble, then we will fix it back. If the fragment is so small that it does not make any difference in the stability of the hip joint, we may excise it out if we are opening up. Many of the time we don't open it up, we just allow it to stay, monitor whether it's likely to malunite or not. Another question is, what about BMP2 and 7 installation? People have tried BMP2 as a avascularity, but the problem is the cost has been exorbitant and literature is not available to validate these things to that level. So we cannot still say with that kind of a firmness that it should be done. Another question is, what makes to choose approach anterior or posterior for fixation? The basic thing is that if hip is dislocated, we will have to go with the flip osteotomy. And for the flip, we go superiorly. As I said, we can go with the KLN flip, we can go with the Gibson and flip. So it is primarily posterior. And if there is an acetabulum fracture associated, we will have to go posterior. But if hip is already reduced and we just have to access that small fragment anterior-inferiorly, whether to excise, whether to fix, in that scenario, we will go with the anterior Smith-Peterson approach. That makes our choice. Another question is, what is the choice of core decompression and grafting method in non-traumatic Picot AVN? Maybe we are a little away from the traumatic AVN, but we do divide our cases depending on the stage. If it is stage 1, meaning by there is edema only, no area defined, even on MRI of avascularity, we do a simple core decompression only with a 4 or a 4 mm Stillman pin from one point entry into the lateral side, and we go into various directions to decompress the femur head without increasing the cortical erosion or cortical inlet. We make the multiple holes. But if it is Piquet 2, in that situation, usually there is a dead area around. In that situation, safest and the least morbid is again to enter into the same area, curettage. Now we do have a kind of a different tools available now to get in with a narrow hole and expand that inside, curate it out, add fresh graft, and in this fresh graft we can add stem cells also, we can add BMP if the people want to use it. That is what our method is. In light bulb trapdoor, because we have been using a best price people also, we have been using other methods also, we tend to increase the morbidity of the area. If overall the femur has not been affected much, and if we are doing it at the stage 2 when there is no collapse, they might be quite useful, and the literature is also supportive. But literature never says near 90% or 80%. They say somewhere around 60% to 70%, and the literature stays at that level where we may not be able to. So we need to discuss all these options with the patient whenever we define that thing. Another question is, any technical details regarding posteriorly dislocated hip of more than 6 months old in adult patient without acetabular fracture, how to reduce on table and maintain it reduced? A simple method, if we want to do a reduction of such a old dislocation. Incidentally, last month we reduced a 12-month-old dislocation hip also. First thing is, we will have to go anteriorly, so we can go with the Gibson, go anteriorly, clear the joint which might have a lot of soft tissue, fibrous tissue formed inside, clear this joint, then release especially the inferior capsule, because with that prolonged dislocation, the inferior capsule is reasonably contracted. So we release the inferior capsule, that does not affect the viability of the vascularity also, and we are able to relax the hip joint to get it reduced into its socket. If we do not reduce it, if we do not cut this inferior capsule, it does not reduce. That is what we say. These are the questions. Any more questions? There is nothing.
Is it possible to
Which one?
Is it possible to hold a large fragment with a single cannulated screw?
Yes, I think I might have missed one question. Is it? It is. Can you repeat the question?
Is it possible to hold a large fragment with a single cannulated screw?
Yes. Usually we never put single. We always put 2 screws, because rotational alteration or fixed stability will only come at least with the 2 screws. So we always use 2 screws. Maybe with the good impaction and the anatomically maintained, 1 screw can also do it out, because it is eventually a interference fit. But for a safety purpose, we always use, because we may not have a very anatomical stability of the fragment at that very site.